Alrighty, so I hope this will kind of convince you people that you can just do a total hip, and maybe there's problems with total hips as well. And to stick up for the trauma people, most of them came from arthroplasty doctors, not trauma doctors. Anyway, so we're going to talk about periprosthetic management in the acetabulum. You've heard other speakers talk about this periprosthetic epidemic, where you got young people like me doing crazy things and getting in bad accidents. This is a gentleman that we'll talk about. And interestingly, you know, it's always after a fall, but there's probably been a lot of damage before the fall. So we'll talk about him. Again, I think the key component of this is stability, and I don't think that dog is safe. Often it just happens from falls. This is a fall that has fracture, but you can see there's some lysis around that cup, and we'll show you some more evidence of that. And here's the CT. So there's already a problem developing, and if you go a little bit inferior, you see the acute fracture that caused the pain. But this is something that was already started. Whether you take these on or not, they can be difficult, but I don't think they're really unmanageable. The problem happens is when this whole thing starts going inward. The first thing I want to do is I want to make sure there's no infection. So we do a bunch of the labs, and we do, I'm an old-fashioned doctor. I actually do a history and touch the patient and then get a CT. In terms of the aspiration, there's certainly a lot of markers. We send it off for tons of things. There is a sampling error. So the culture can be less than 50% accurate on the actual culture showing something, but you have to remember, we can only culture about 1% of the bacteria that's out there. So a lot of times if they're on antibiotics, I'll wait 1 to 2 weeks. But some of the things like alpha defensin, it doesn't matter whether you're on antibiotics or not. Alpha defensin is a protein that's produced by the body in phase of infection, up to 96% accurate. There are false negatives. I do have to send it out. So on JP, he had significant pain with ambulation. That was a constant pain. He had an elevated SED rate CRP. He had no thigh pain. That's important to me. So when he does flexion against resistant, it's more in his groin area. So I'm thinking that his stem is good. He did have a positive alpha defensin, but the cultures were negative. Your options, you can do a 1-stage, you can do a 2-stage, or a partial resection. I tend to favor the 2-stage, but can answer questions about the other ones. In the face of a positive alpha defensin, I'm thinking it's probably infected. So I think of this as tumor surgery. I basically, all the devitalized tissue, anything that's exposed to that implant, and the implant's coming out, and if you're going to do the 1-stage, you got to re-prep and drape, and then you can certainly do that. I think prevention, you also need to think about that, and it's the medical optimization of the patient, so make sure that all of those things are done. And certainly I get a lot of Jehovah Witnesses where you get cell saver, TXA, and then kind of a bipolar device. So in terms of making it, I call it a nuclear bomb of antibiotics and antifungal. So I use a 36 gauge chest tube. I make my own prosthesis. They have some out there, but I don't think they have enough antibiotics for me. So I use tobramycin cement, and for every bag of cement, I do an additional 3 vials of Vanco, Tobra, and then usually if it's been a while, amphotericin, because it might be draining, or a fungus, so it depends on the timing of it to some degree. You can do specific for the cultures, but they have to be heat stable. Hemovacs, incisional vacs, those kind of stuff are used after the kind of the 2nd stage. So I actually like the antibiotics draining out. And so this is us just making it with the French tube, and we use a guide wire that you ream, and we bend it, and then we stick the head of it into one of those green Davol sucker heads that I put mineral oil in, so that way it can come out. And essentially that's what it looks like in the body with the antibiotic beads as well. And usually I use 2 bags of cement with 6 of all of those things that I can make beads as well as a spacer with. This is a gentleman, just to show you the problems. So many debridements. He had, even before he got to me, they still had problems with. Eventually we got it clear, but look at, he doesn't have, this is all of his femur he has left. Now, scares the crap out of me, but he's still doing good about 5 years afterwards, but that one's one of those things that I'm very worried about. My protocol is essentially with an infected implant, 6 weeks of IV antibiotics. 6 weeks, I do a WBC, sed rate CRP when we stop the antibiotics. I do it at 7 weeks again when I do the aspiration. I like to see those numbers going down. If they go up, that's a bad sign that I need to do another debridement. So at 8 weeks, we hopefully either do the real thing or we repeat the debridement. And you might ask me, I've had to do that 5 times. So it's not a 2-stage approach. It then becomes a 7-stage or 5-stage implant. I do think the CT is important for a couple of things, especially in JP. I'm not sure where I'm going to get stability. And before you put an implant in, I need to have stability of the columns, and I need to have stability of the rim as well. So I have the defects. I want to make them contain defects, and maybe I have to kind of fix the acetabular fracture or whatever you make because of the pelvic discontinuity. So here's his CT. There's really nothing there to repair, and so I've got to probably have to fix it with some type of allograft that I use once I get the infection. I think this is important to look at the stem, but that slide or the picture his on the left side, it shows that spot welding that I talk about. So the bone, even though you might see some lysis on the side or whatever, there is some bone that looks like it's really affixed to that prosthesis, and his physical exam goes along with that. So the key is trying to get a solid cup in there, whether you use a jumbo cup, a oblong. My probably go-to on most of these really bad ones are a cup cage, cup construct. So the idea, you put a jumbo cup in, you put a cage in there, then you cement a cup in there at the once you get everything stabilized. But a lot of times I need to get basically continuity of that pelvis again, so I got to use some mesh and potentially some allograft as well. So here's an example of a different kind of case, but it's a contained defect. And again, I use a jumbo cup, put a cage inside of it, and then cement a cup into it. And I've kind of restored that hip center to the right place. Another one that I had to put more of an allograft in, so I had to fix it. And then this is maybe a little bit older because I used one of those, we called it a Lone Star plate. Then I put a recon plate over it to buttress it. And then the idea being is that that kind of prevents that hip from going medially. And then another example of that. And that's now Stryker has a nice plate that allows me to do it all in one, that basically kind of gives a little buttress plate on that quadrilateral surface there. And then you can do your total hip on it after you get it stabilized. And I think the key is to make sure you stabilize, make sure you get the rim stabilized. Sometimes you can use some tantalum augments, and I think I have a picture of that. And then sometimes I use allograft as well. So here's one with some tantalum graft or tantalum augments, basically trying to get a stable fixation for that cup. Here's a gentleman, unfortunately, kind of was fixed across the street, and unfortunately I fixed his right side with a femoral neck fracture that fell apart, and so eventually got to me. And he's a young guy, I can't remember, 35, he's 35. And so I could use some allograft there a little bit, and I got some allograft that we put screws in the direction of the stress and put the hip in, we kept them off of it. But these bulk allografts can take up to 8 months to heal. The remines are a little bit better, maybe 2 or 3 months, but I think that's what that's saying. But you got to think about that a little bit. I don't keep them non-weight bearing for 8 months, but it is concerning a little bit. Sometimes it's not done well, and the hip's way up high. How do you get that back down? I know this is miserable. It looks like a torture device, but we basically put an Alizaroff on, pull the hip back down to the proper thing, and then you can put a hip in the proper position. So another one that what happens sometimes is the poly wears out, you get metal on metal lysis, and the whole thing gets into the pelvis. And that's why I follow the hips at least every 2 years, because if I see some eccentric wear, I can go out and just switch the poly. If you wait too long, then this is a much harder case to do. Again, it was infected. We had to wait a little bit. Really nothing there. we ended up putting the allograft in first, let that get stronger. We kind of fixated it with this plate, and then eventually we were able to do the hip replacement. So JP was somewhat similar. We put a plate in there with some allograft, felt like we got a pretty good stability of it. Now you can see that's like really vertical. That's not the real cup portion per se. The poly we've cemented into it. So I put that big cup where I can get some stability, then I cement inside the cage the polyethylene cup and put that at a better position. So the key, make sure you get a stable implant before you put anything in there, or a stable column and rim. Otherwise, it's going to fall apart very quickly. Thank you.